The management of patients, protecting them against COVID in the future, is now very clear, in my opinion, at least. So, of course, vaccination is a cornerstone, 3 baseline doses, and then booster doses in short intervals with the new vaccines, with the bivalent vaccines from Moderna or from Pfizer. The question is in which intervals, because we know that the antibody titers wane with time. But antibodies alone are not only protective, we need also T cells. So there is a certain area of, let's say, uncertainty, what is the ideal time interval for the next booster vaccination. I would suggest 3 to 6 months, depending on the patient's situation. If it's a patient who had 15 infections before coming to the vaccination, I would rather opt for a short interval. If the patient comes in and doesn't have a history of previous infections, I think you can then, of course, use longer intervals, but that is not based on scientific data. That is only what I'm doing in practice. Again, but if a myeloma patient has contact with a COVID-positive person or has been shown to be positive, he should be on prophylaxis for developing severe disease. And the most appropriate treatment is Paxlovid. So 3 tablets in the morning, 3 tablets in the evening, 5 days. This gives a certain, I think, significant protection, but not 100% protection. If Paxlovid is not available, you could use remdesivir also for about 5 days, and that is what can be done. Previously, there were also monoclonal antibody cocktails available for prophylaxis and also for treatment. But these have been shown to be not active against the Omicron variants. There's a new monoclonal antibody which is being developed, which will be available probably by the end of the year, which may then be used. But at this time, monoclonal antibodies or convalescent sera have no significant activity against the newer Omicron variants. So treatment relies on Paxlovid and remdesivir.